Good afternoon and welcome to SHM's Practice Management Webinar Series. This series brings together experts from across the country to cover hospital medicine's most pressing operational topics. We are joined today by 4 hospitalist leaders who will be having an open debate-style discussion on the value of co-management. From Riverside Regional Medical Center in Virginia, we welcome Dr. Hardik Vora. From Norfolk General Hospital in Virginia, we welcome Dr. William Atchley. From WVU Medicine, Camden Clark Medical Center in West Virginia, we welcome Dr. Deric Bryant. And from Duke Regional Hospital in North Carolina, we welcome Dr. David Boyte. Surgical co-management largely declined during COVID-19, but as vaccines are rolled out and elective procedures begin to ramp up again, the clinical and operational value of co-management post-COVID is a timely discussion for today. Our panelists have taken 2 perspectives. One, presenting the benefits of co-management, and the other, showcasing its weaknesses and challenges. Do we resume things post-COVID as normal, or are there changes and new use cases that can improve this prolific and debated system of patient management? We invite you to join with our panelists during a dedicated time for Q&A at the end of the webinar, questions for which can be submitted at any time on your control panel during the presentation. For best audio quality, please call into the webinar by phone and link directly to your computer. Your microphones have been muted, so please use the chat feature to communicate with us directly if you experience any technical difficulties. This live webinar and other COVID resources have been made freely accessible to the public. Resources such as these are only made possible through member dollars. If you find today's webinar valuable, we kindly ask that you consider joining SHM to ensure continual access to the content you need most. Free CME credit will be available for this webinar exclusively to SHM members on our online learning portal. Without further ado, I will now turn things over to today's moderator and the chair of the Practice Management Committee, Dr. Hardik Vora. Dr. Vora, the floor is yours.
Thank you, Luke, and thank you everybody for attending. Today, as a start to get started, we'll go around our virtual table and introduce ourselves. I'm Hardik Vora. I'm practicing hospitalist and medical director of hospital medicine at Riverside Regional Medical Center here in Southeast Virginia. I also serve as a chair of Society of Hospital Medicine's Practice Management Committee. And back in 2017, Bill and I, along with other physician leaders across the country, collaborated on a co-management work group and produced a white paper, The Evolution of Co-Management in Hospital Medicine. It is available on SHM's website under the Practice Management tab, and I highly recommend using it if you are working on it, getting into a co-management relationship, not just because of, we authored it. I think it has a really valuable information, so I would definitely recommend that. In today's discussion, I'll be partnering with Bill, and we'll share our pitfalls and challenges related to co-management, especially in the community setting. With that, the mic is yours, Bill.
Thank you, Hardik. I'm Bill Atchley. I am a practicing hospitalist at Centera Norfolk General here in Norfolk, Virginia, just across the river from Hardik. I am the point hospitalist at Centera Heart Hospital, which is on our campus, which is a 114-bed hospital, which is strictly devoted to cardiac service line, which 40% of the patients that are there are cared for by our hospitalist team. I've been a practicing hospitalist for 25 years, and as Hardik mentioned, I was one of the co-authors for the paper and also was part of the presentation in 2017 out in Las Vegas when we talked about co-management. And I will turn it over to David now.
Thank you, Bill. It's a pleasure to be here discussing co-management with you all. I really appreciated the white paper that Hardik and Bill and others put together and would recommend that as well. I am a hospitalist at Duke Regional Hospital in Durham, North Carolina. This is one of Duke Health System's 2 community hospitals outside of the University Hospital. We have a single hospital medicine group that serves all 3 hospitals, and I'm based at Regional since 2007. I was involved in starting up a pre-op clinic in 2012, and I'm the director of perioperative medicine here. The idea was one-stop shopping in a hospital-based clinic in close collaboration with anesthesiology, where surgeons refer their patients for medicine consultation preoperatively. The idea from the beginning was to have a perioperative surgical home model where we encourage orchestrating patient care from pre-op to discharge, being a single node of communication and decision making. And then by 2015, we started the post-operative co-management service, initially with orthopedists and then expanded to other service lines as well. And we continue to develop that service line. So, you know, when COVID came, I think some of the surgeons were a little worried we may have to use our APPs to be hospitalists for COVID patients. And we did train some to do that when the elective surgery cases were down. And the surgeons were perhaps a little worried they were going to have to take care of some of what we were doing post-operatively. As it turned out, with the elective surgery cases interrupted, that never did happen. And then our APPs were available again once those cases ramped up. So looking forward to learning a lot from the rest of you here. Deric?
Deric, your mic is.
Sorry about that.
No problem.
Yes, I'm Deric Bryant. I'm the medical director of the hospitalist program for WVU Medicine Camden Clark Medical Center in Parkersburg, West Virginia. We are a 26 provider program, maintaining a census in our hospital of about 200 patients, just over on average. We are your traditional community hospital. We are a referral center for several critical access hospitals in our area. We work with several surgical and subspecialty lines within our hospital here. We've had co-management relationships, many of which were more laissez-faire, so to speak, and others which were well-defined. And we've seen the benefits and advantages, as well as the disadvantages of your more traditional attending consultant roles compared to our co-management roles. During the COVID pandemic and during our planning phases, we relied heavily on our co-management tools to provide a method of caring for patients with the resources that we had in our hospital without having to rely more on our tertiary care centers and their neighbors. By utilizing a co-management program with well-defined roles for hospitalists, pulmonologists, and critical care specialists, we were able to comfortably maneuver a pandemic which put a real strain on many of the resources top to bottom in our hospital, from ER to general internists to hospitalist specialists to critical care specialists. So by developing good co-management tools, we found that we were going to be, we had a better chance of success through a time when we were going to have a real strain on our system. So today I will be providing some information on the advantages of co-management along with Dave.
Well, thank you, gentlemen. So since we have introduced ourselves, let's learn about our audience today. We have some questions for the audience to see, you know, how they are engaging and what's their current role in co-management. So we have some audience poll question here. The first one is, what is your co-management role with the medical subspecialties, excluding oncology? So what is your role? Are you attending or admitting, consultant, variable, no interaction? We'll give you a few seconds to submit your response. All right. So we have 56% admitting and attending, 22% in a consulting role, and 33% variable with 2% no interaction. And this mirrors, this question and the options mirror the State of Hospital Medicine survey, and you can look at the national results through the State of Hospital Medicine in the State of Hospital Medicine survey. Let's go to the next question. What is your co-management role with oncology? Oncology comes up quite frequently. I think recently there was an HMX post about oncology, co-management with oncology. Oncology is a unique medical specialty, so we'd like to kind of explore that role a little bit separately than the general co-management with other medical specialties. Let's see what our audience is saying here. It looks like we have a more, clearer roles here. Either you're attending or admitting, or you have basically no interaction. All right, let's move to the next question. What is your co-management role with surgical specialties? And here we will exclude orthopedic surgery in your response. All right. These are some interesting results, I must say. We have an interesting audience today. About 80%, only about 80% in attending or admitting role, 38% in a consulting role, and about 40% in with the variable roles there. And let's go to our last question on co-management roles. What is your co-management role with orthopedic surgery? All right, we have quite a split here, about an even split, 30% attending, admitting, 35% in a sole consultant role, and about 35% in a variable role. So that's, now that we know how our audience is involved in co-management, let's dive into the debate. So let me ask this question to Deric and David. Is the co-management still necessary, or is it still valuable? What do you guys think?
Well, thank you, Hardik. I think co-management has a lot of value to it, and especially when we're talking about not just traditional consultation where we may give a recommendation to a specific question that's asked, but co-management where we have well-defined shared responsibility with another set of providers, writing orders, not just giving recommendations, and not signing off, but following the patient to the end of the hospitalization. And really, what better place to start than patient safety and quality? That's where we're most concerned. This model provides for the most appropriately trained provider to address the issues at hand. Many of my surgical colleagues tell me that most complications of surgery are medical in nature, and certainly we see that. Of course, rarely a patient has to be taken back to the OR for internal bleeding, but that's not nearly as common as the medical complications that happen post-operatively, whether it has to do with vital signs or symptoms or brand new issues. Most of those need medical intervention. And I tell our students that if you apply the grandmother test, if your grandmother just comes out of hip surgery, would you rather the orthopedic intern or the experienced hospitalist be called with a blood sugar of 400? And this is really the teamwork that is possible in more and more hospitals these days where we have hospitalists available. That's not to mention the availability of the hospitalist often compared to the surgical team who may be in the OR, who may be out at their office while they have patients in the hospital. Hospitalists are typically in-house, even in the evening. We're available to meet families and their caregivers of the patients on their schedule. As far as safety, also we're there to prevent complications. We study and know what common ones would be, and for certain patients with pre-existing conditions, and we want to find them early. We're focused on prevention, perhaps more than the surgeons or the subspecialist. And when we find issues early, we can manage them early and perhaps prevent further complications or transfer to the ICU, perhaps further delirium or further infection or sepsis and this kind of thing. You know, at the end of the hospitalization as well, we are available as hospitalists to hand off the care, the post-acute care, to the most appropriate outpatient provider. The surgeon may have the patient go back to their PCP. We can arrange follow-up, sometimes with ourselves if we have a dedicated clinic, with a PCP, or refer them to a new subspecialist that needs to manage their new problem. Also, hospitalists pay a lot of attention to an accurate medication reconciliation, and we can offer our skills in that manner, providing for patient safety. Deric? May still be muted.
Yeah, you make some great points there. You know, I don't have to look back very far in my day-to-day to think of exact instances where that mattered. In fact, just yesterday morning, post-operative patient within 24-hour window of surgery developed some left-sided facial droop and left-sided weakness. Not at all considered to be a expected complication of the procedure that he had. And because my service had been involved in his care from the beginning, we were able to rapidly intervene on what was clearly a very serious medical issue, which he was at increased risk just from having been under anesthesia recently. And so it just goes to show that, just as you said, we want to have those specific providers providing for and giving the care that they were meant to give. And the co-management relationship allows for that. And it's not just the patient safety and quality that is improved, it's patient satisfaction. You know, we as hospitalists, HMG specialists, we are communication experts. We're discharge planning experts. No one communicates with a family or a patient on the level that we do day in and day out. It's one of the cornerstones of what we do as medical providers. Having us involved top to bottom means that we are going to be bringing that skill from day one and throughout the stay for the patient and their families. Also, with the quality improvement measures that David just enumerated, you're going to see patients be more satisfied with their outcomes. I'm more likely to be satisfied with my procedure if things go well from a quality standpoint. And lastly, having clearly defined roles that only come from a co-management relationship means that patients and families have a better understanding of which physicians are providing which services during their hospital stay, especially when everyone's on that same page. A co-management agreement, which is well documented and then communicated well to patients, families, nurses, and the rest of the care team, means there's going to be less frustration for patients and families throughout the course of their stay. In that traditional attending and consultant role, there's going to be more overlap. There's going to be more of a tendency for some scope creep to occur, and that's going to lead to some frustration on the part of the patient and the rest of the care team. Lastly, the agreement and having a co-management agreement or relationship means that the hospitalists and the surgeons have the opportunity to manage up one another They have the opportunity to demonstrate to the patient, hey, you know, we're working together and we are all on the same page here to make sure that this procedure goes well. You and I were talking about some of the situations in which you've experienced that, David.
That's right. I was letting Deric know that I don't know how many times, it's really daily or multiple times per week, that a patient is so relieved when I sit down with them and make eye contact and tell them how great I think their surgeon is. They feel like we're on the same team. I'll say, yes, that surgeon operated on my wrist, or I have sent multiple family members to her as well, and I really trust them. If those things aren't true, then I'll say, you know, your surgeon's very experienced. We've been sharing patients for years, and I think you're in very good hands. I'm going to help you through it, and they appreciate that.
Yeah, thank you guys for sharing your thoughts on
I'm sorry, I think Deric was muted again.
That's okay. Go right ahead. We have a few more, but I want to go ahead and hear what Hardik was.
No, go ahead. Finish your points. Yeah, absolutely.
Oh. No, I mean, along that line, you know, I think surgeons would be definitely, surgeon subspecialists are all going to be more satisfied if the patients are happier and we have that kind of relationship that we're sharing with one another. I think more though than just surgeon and subspecialist satisfaction, I think that a co-management agreement will contribute to an increase in their availability, and that's where the satisfaction is really going to come in. You know, some people may argue, yeah, of course, the subspecialists, of course, the surgeons are going to be more satisfied. We're doing all of their work for them. Who wouldn't be more satisfied in an arrangement where we do all the work? Really, though, what we find in these relationships is that the satisfaction doesn't come from having someone do your work for you. The satisfaction comes from having a surgeon and subspecialist be able to work at the peak of their skill level day in and day out. Do the things that they wanted to do, do the things every day that motivated them to get into the field that they're in. Same for us. You know, by way of a co-management agreement, we are able to provide the services that we're best at for the patients that need them in that perioperative period. And the surgeons are able to provide the services that they're best at during that perioperative period. That is going to lead to a professional satisfaction for our surgeons, our subspecialists, and, you know, in the long run for us as well as clinical providers, in a way that the traditional attending and consultant role may prevent from happening. I don't think that a co-management agreement is an us or them relationship. Instead, I would argue that the attending consultant role has more of a tendency to lead to that us or them, who's going to do the work and who's going to do the grunt work in this scenario. And David, you and I were talking about some of those scenarios where that comes into play.
That's right. You know, that brings us a bit to the financial improvements, and I'll try just to highlight a few of those potential improvements. When you talk about surgeon satisfaction, those of us who are hospitalists may not initially care a great deal about the surgeon's satisfaction. However, this is a big selling point, maybe for our hospital leaders, and surgeons, particularly at community hospitals, may have a choice of where to practice. And if they can work on at the top of their license and not do some work that others are better suited to do, then they're happy, or maybe they'll bring more cases. Maybe other surgeons will be recruited. In our pre-op clinic, we create a document that many of our surgeons adopt as their HMP with a brief addendum, and then they don't have to do that. Another way that hospitalists can contribute, though, whether it's on a surgical service or subspecialty, is with documentation, optimal documentation. Of course, surgeons are typically compensated by procedure, but hospitalists by their documentation, so we become experts at that. The details in our documentation can help lead to an optimal mortality risk calculation, and that can affect reimbursement, as well as comorbid conditions or major comorbid conditions to lead to optimal DRG coding and then reimbursement. We pay attention to careful documentation around some post-surgical issues so that charts are not inappropriately flagged for PSIs or patient safety indicators that they should not be, also leading to improved reimbursement under value-based purchasing models. In some settings, there could be an improved length of stay. That's not the case everywhere. Sometimes surgeons have a very short length of stay, but certainly perhaps with other specialties and at individual locations, that may be possible. You know, there are ways to save cost with such a model. APPs can be employed. You know, when I'm writing a post-op medical note, I might bill a level 1 or 2 as opposed to a 2 or 3 for a hospital medicine patient. But I can typically see more patients in one day, and that helps make up for it. You know, there are many ways to potentially impact finances within a hospital medicine group on such a service.
Yeah, I think the hospital skills and abilities are just as crucial as the surgical skills and abilities when it comes to that co-management relationship. The hospital skills, hospitalist specialist skills when it comes to kind of navigating the service pathways within a hospital. Again, a thing that we are experts at, a thing that we do day in and day out. You know, the skills we bring with regard to managing a multidisciplinary team and getting the most benefit for our patients, even post-discharge, which we covered earlier about under quality and service. Those are the things that are going to have financial impacts. They're going to have patient satisfaction impacts, and they're going to have impacts overall on the patient's stay. You know, our ability to navigate a system with case management, social work, and how they're going to influence the long-term care is going to make a big difference for our patients in a co-management relationship.
That's true. As hospitalists, we're aware of hospital-based resources, community-based resources that can serve a patient whose discharge plan seems to be becoming difficult. We know how to navigate that. Our cognitive skills and those medical and operational decisions can serve these patients and surgeons well. Our focus on prevention, even long-term prevention, not just within the hospital, but doing what we need to try to prevent readmissions. Our focus on high-value care, high-value cost-conscious care can impact other service lines. And we've already mentioned our 24/7 availability. Since we're not in the OR, we're usually in-house. We're getting the pages in the middle of the night about medical issues. I've had surgeons tell me they sleep better at night, less interruptions since we're helping to manage their patients. So I think we have a long list of pros that we've just touched on here, Hardik and Bill. What do you think?
Yeah, well, thank you both for sharing your thoughts. Bill, how do you feel about what Deric and David just said? What's your experience?
I wish I had a slide basically from the Dan Aykroyd, Jane Curtin era Saturday Night Live with the point counterpoint here right now, but I don't. I think what Deric and David have talked about, I mean, there certainly is a lot of value in everything. I am a little bit concerned that when you look at things over the last 20 years, I mean, what does the data say? And when you review it, you know, I mean, it's kind of plus minus, and it's been focused mostly on orthopedics, neurosurgery, maybe a little bit of length of stay improvement, maybe a little bit of, you know, cost savings. Recently, you know, this past August, there was an article that was published in the Journal of Hospital Medicine looking at morbidity and mortality for hip fractures, and there was no benefit. And in fact, there was an editorial that accompanied it at that time saying maybe there needs to be randomized controlled trials for this. I think that, you know, Rogati out in Stanford, where they have dedicated hospitalists for neurosurgery and for orthopedics, where that's all that they do, their 5-year experience was pretty impressive in terms of showing, you know, about over $3,000 in terms of direct cost savings. And the focus has mostly been on surgery, what we've been talking about, but when you look at what we do besides surgery, we are also doing things with the medical subspecialists. And there's not really any data out there except for maybe, I think, one study looking at hepatology showing maybe some benefit there. So we've not seen, are we making a difference in heart failure? Are we making a difference in those cardiac and those oncology patients? You know, that's a question. I think, you know, in the patient satisfaction sort of things, I mean, it's like, you know, we never really ask the patients, do you want to be taken care of by a hospitalist when they're coming through the emergency room? You know, if you're a if you're a patient with a cardiac issue, you want that cardiologist. If you're an oncology patient, you want your oncologist there. So I think it's kind of important for us to understand the patient's preference and everything. And you know, HCAP scores unfortunately don't capture, you know, and can't kind of separate you know, just what hospitalists are as part of that role. And you know, anecdotally, my experience with taking care of the cardiac service line is that trying to make sure that if I'm talking with the patient, their first questions are always, when am I going to get my procedure? And when am I going home? And I sometimes have to kind of you know, bracket that a little bit and say, well, you know, we need to be talking with your subspecialist for that. So, you know, I think that those are some of my concerns there. I mean, yeah, everyone, surgeons and subspecialists, they're going to be very happy about doing this. I mean, you know, and I can just tell you, 25 years ago, cardiologists thought that it was the worst thing in the world that hospitalists was going to be admitting all their chest pains in 1995. Guess what? 3 months later, they were happy we were doing it. Hardik, I'll turn it back over to you to finish up then.
Thanks, Bill. Yeah, no, I think, and I think to Deric's point, I think surgeons are happy because they can, that they're doing the work that they're trained to do, and they're spending more time doing that. I would argue for hospitalists, it's actually the same way. I think when we provide a lot of, and this is again anecdotal, talking to the you know, my colleagues and hospitalists across the country, that is the part of our dissatisfaction, because we're, you know, most of us trained in internal medicine, we're not trained care coordinators, right? I think so. We're not, when we are engaging in some of this co-management relationship, we're actually not providing value. When you admit a hip fracture that has really no or very little medical problems, it's not intellectually stimulating. And I think I would argue that that our satisfaction is actually lower. And to that effect, on the patient satisfaction, there's actually literature that shows that there's no improvement with on patient satisfaction. There's actually a couple of published articles that have looked into patient satisfaction, and they found no improvement in patient satisfaction related to co-management. And partly I feel like it's because, you know, when somebody comes in with a hip fracture, and I'm just using that as an example, they want to talk about what's going to happen to that hip fracture. When are they getting surgery? What to expect? What are their options? And we're sometimes not best positioned to answer questions related to the acute issues. They may have diabetes, but they're not interested in talking about their metformin at that time. You know, they want to know what you know, what they're there for. You know, they have questions related to the acute condition. And as for the surgeon's satisfaction, I must say, you know, it might sound controversial, but I don't really care about their satisfaction. What I care about is our colleagues and our hospitalist satisfaction. And to that point, we have a pretty large audience here. So let's ask our audience. You know, we have hospitalist colleagues across the country, and we want to ask them that question. How satisfied are you with your role in co-management? And you have some options here. I'm not going to bore you with them, but if you really love it, you know, you can give it 5 out of 5. I can do co-management all day. You know, if you can deal with it, you know, if you feel like you're adding value, you can say you like it, and then you're adding some value. If you're indifferent about that, you know, that would be a good number 3 to click. And if you don't like it, but this is what hospital medicine is now. You can click on 2, and of course, you know, if you hate so much that you regret doing hospital medicine, you can click on that as well. So let's see what our audience say here. I think we have about 50% voted. We have a good split. I think there are about 40%, 43% who feel that they are adding value. And then we have about 6% who can do co-management all day. So that's about 49% between them. So that's, and then we have about 50-50 split in that regard. All right, in the interest of time, we're going to move on. So, Bill, what are some pitfalls of co-management? Let's talk about that.
I think certainly, you know, the concern about scope creep is something we need to be kind of thinking about. I mean, you know, I know that there are things that we are asked to do that are outside of our training, and I think that that is something that either we're going to have to change things in terms of our training programs so that people feel comfortable taking care of neurosurgical patients, or, you know, are we going to be having to provide some other methods of training so that people feel comfortable with that? Because I think there was a poll in today's hospitalists where that people felt that they were being asked to do things outside of their comfort zone and everything. So, and that's where I think a good co-management agreement comes in effect, because I think if you really don't periodically go back and look at things, I think that you can be starting to be asked to admit a lot of patients that necessarily that you're not providing any value to. I am very, very worried as an unanticipated consequences of things about confusion that is going on in patients, particularly when they have multiple subspecialists that are involved in their care medical centers. I kind of see that, and I've seen that a little bit more in the last couple of years as to, you know, who is doing what, and you know, I think that again, that's where people need to be kind of coming back and talking, and I think that's where it's important for service line agreements where that the ones that are successful is everyone basically comes back and talks with each other. I think that where there is some concerns is where you do a service line agreement and basically it gets put into a folder and no one really looks at maybe it again until there's a crisis that goes on. And I think then the you know, I think there is sort of this disengagement sometimes that can happen with subspecialists. I mean, at my institution, if you come in with a stroke, the neurologist signs off usually within 24, 48 hours, leaving you kind of be having the discussions afterwards. And I think that that puts the hospitalist into an uncomfortable position in terms of talking and things. And I am concerned with dissatisfaction and burnout with this. I mean, this is, you know, I mean, co-management has been going on, you know, for over 25 years now. And I've seen things happen very differently in terms of what our responsibilities are now versus what my responsibility was when I first started doing this. And I think a lot of it is more non-clinical things that are being asked to do. And I think Hardik, you mentioned a little bit earlier about being involved with case management, or, you know, having the copy and paste in the information so someone can get a semi-electric bed at home or a wheelchair. That's not part of why we got into this. I'll turn it back to you.
Yeah, and I think those are great points. I would also add the increase in redundancy. I think it's very true with a lot of medical subspecialties. You know, how many times we have seen two physicians essentially managing the exact same problem, and when we are short on resources, and we found that out, you know, during our COVID surges, where you're spending time on patients where you're really not adding any clinical value, and I think the operational value, as we talked about, is there, but I think there are better ways to do that, and that I think it would be a better and a cost-effective model if we had a subspecialty services have their own advanced practice providers that can collaborate with hospitalists more in a consulting role and help them manage their chronic medical problems. It would be more cost effective and more better use of our time and our skills. So certainly do that. When you involve yourself in a low value co-management relationship, especially when you're not adequately staffed, you really need to look at that. I've reminded my chief of cardiology here one time that a locums hospitalist cost more than an interventional cardiologist, and that's a true statement. Those of you who have hired locums physician and the cost of the program, you know this, and you really have to use your resources wisely. If you have adequate staffing, if you're fully staffed and you have excess capacity, sure, you can do a little bit of that, but not when you are short on staffing and certainly when you are understaffed. So I think those are some of the consideration I would definitely ask you to consider. So let me move to the next question, next big question. Should the co-management be synonymous with assuming a tending role? What do you guys think?
Yeah, I think that the attending consultant role, and I think a lot of hospitals still use these. A lot of community hospitals still use this. There are several service lines where we still use that role. But in a good co-management agreement relationship, where everyone has defined what their roles are going to be clinically and logistically, then who is the attending and who is the consultant becomes of a lot less consequence. Because those roles within the continuum of the patient's stay and that perioperative period have been well defined.
I agree that it could go either way, and you need to determine who the stakeholders are and how meaningful these decisions are for them. For instance, you talk about scope creep. Maybe it would make a difference for the hospitalist if we were not the attendings, but had a formal co-management model to address certain issues and didn't have to do the discharge summary. That's the way we often do it, and that can help prevent the scope creep. By the way, I do think that idea of scope creep can be turned on its head and turn it into a leadership opportunity for another budding leader who might want to become an expert in that field. Maybe there's a hospitalist who wants to become an expert in the oncology service or the neurology service. Maybe that's an APP also, and they can help design and run that service and educate the other hospitalists. I think we've seen that happen in our system. As far as the dissatisfaction, if we help spin it the right way and encourage budding leaders, as long as we're adequately staffed, then that's a way to combat that problem.
So yeah, I think I would argue that the attending role, as Deric mentioned, if you have a very good co-management agreement, it shouldn't really matter who the attending is. But I can tell you, so when we hear co-management in hospital medicine, we hear all the good things that David and Deric has talked about, right? That we're taking care of patients' chronic medical issues. We're making sure we're getting the MedRec right. We're identifying acute medical issues, and we're partnering with surgeons in providing care for some of the surgical and medical subspecialty patients. You know what? The surgeons and the medical subspecialists here admit to hospitalists, and I'll consult, and they sign up as fast as they can. So I think the attending role is, and I think that, you know, jokes apart, I do think that the attending role should really be defined, be assigned based on what's going on, what's the principal reason for admission, right? Why is this patient in the hospital? And that can change throughout the hospital course, but I think the attending role should be assigned based on why the patient is in the hospital. And then they may start out being on a surgical service, and then they may develop acute medical issues, and there may need to be a handoff. But having a hospitalist being attending on a patient where they really have no input on the acute condition why the patient is in the hospital for, that's a recipe for disaster. I think, especially when you don't have a very engaged subspecialist. With that, you know, I think one of the things that was talked about is, you know, do you have a good co-management agreement, right? And all these problems can be solved if you have a good co-management agreement. Let's see what our audience think. Do we have a good co-management agreement? You can say yes, agreements are well written with clear definition of roles and responsibility, or no, we just do what we're asked to do. Where do you guys fall in that? So I think we have a good, I think we have about 51, 52% voting, and we have about a nice 50-50 split here, which is very interesting because when you talk about having a right I mean, a lot of us are doing co-management, but if 50% of us don't even have a written agreement, I think that's alarming, because as you know, we have discussed throughout this debate that, you know, the key to success is having a well-defined co-management agreement. So let me ask our panelists here, how do you get the co-management right, and what happens when you don't?
Yeah, I'll refer you back to the white paper that David mentioned earlier. I would start there. If you don't have a co-management agreement, that paper outlines all the keys to success. Several articles have discussed a lot of the challenges. You know, you can find these multiple places, but several articles discuss those challenges that are going to come up as you plan your co-management agreement. What I think, if you haven't attempted it yet, if you're starting the process, you may be surprised how easy it is to plan out the logistics. You know, who's going to round and who will be here and that. What might be sticking points and what can be more difficult to hash out is what the clinical roles are going to be. You know, who's going to be responsible for consulting infectious disease specialists, who's going to be responsible for, you know, pain medicine scripts post-operatively. Those kinds of things need to be discussed and laid out ahead of time so those roles are well defined. And when you don't define those roles, it's going to lead to more of the frustration and more overlap and more redundancy, some of the things that you guys mentioned in your disadvantages.
Yeah, I think agree with that. So our consensus, you know, while we have different views on co-management, its value and it's challenging, I think our consensus is co-management is here to stay, and it is valuable if you do it right in a targeted fashion. So what are the hallmarks of effective co-management agreement? So Bill, do you want to take a shot at this?
Sure. I mean, I think that, you know, I'm not going to run through all this because I think everyone can read the slides and things, but this is reflective, really, what we've had within SHM in terms of workshops and in terms of the white papers and everything. And I think that the whole thing about being bidirectional is important. I think it being patient-centered, like I said, it's all about the patient and not about, you know, the physician, and about coming up with some clear, you know, lanes of, you know, where we work and everything is important. And certainly having conflict resolution is important. One of the things that I think is also very, very critical is really looking at the data to see how you are performing. I mean, it's we start these service line agreements, but I think the programs that are successful are the ones that really kind of look and say, okay, are we decreasing length of stay for hip fractures? Are we decreasing length of stay for heart failure? And kind of go down the line and look at it. What are our, how do the scores look when we're co-managing with our subspecialty colleagues to see if it is making a difference or not, because it may not be making a difference. And if it's not, then the question you have to say is, okay, how do we make a difference? How do we improve things there at this point? Because particularly in this day and age, with how much money that is being allocated for a hospitalist position. When you look at the state of hospital medicine report, it's close to $200,000 now per FTE per year. That adds up. And so I think the C-suite is going to be looking at that investment, and they're going to be taking a little bit deeper dive into looking at things like readmission rates, morbidity and mortality, looking at the things that makes a difference with their scorecard. And so if you have those agreements, I think it's critical that your agreements are in alignment with what is important to your hospital or your healthcare system.
Yeah, and again, I think a couple of other things I would add here is the attending versus consultant roles, right? That comes up all the time. And if you have a bidirectional agreement, like Bill said, and hospitalists and subspecialists have equal stake and stay in the structure of that agreement, it really shouldn't matter. And then a lot of those are local factors, your organization's culture, availability. I mean, if you're practicing in a rural setting and when you only have one surgeon, that person cannot be on call for 24/7. But if you're in a decent size community or academic program, that argument that somebody down the road doesn't admit any patients, why should I, just doesn't fly. And I think we have to be very cautious, especially as hospital medicine leaders, because this is where I think we do need to draw a line somewhere where we're doing the work that is valuable, intellectually stimulating, and we're not being dumped on. That's the feeling that majority of us sometimes feel in this co-management relationship. You always want to have a conflict, a mechanism to deal with conflict, and they can be operational or clinical. You always want to have those mechanisms in place, and that's why it's important to have something written down. And the one last thing I would highly recommend is doing a systemic review of these agreements to see if they are actually doing what we think it's doing. And as you can see, the literature is very conflicting right now on co-management. Even in the most controlled setting, you would hope that when the research is being conducted, all parties are at their best behavior, which not always is the case in a community setting. So you can kind of see that even in the most controlled setting, the data is at best equivocal. So we really should do a systemic review of these agreements, and staffing situation may change. A lot of things may change. And COVID was a perfect example, right? We were in the middle of pandemic. A lot of programs where the specialists helped out and stepped up, and there are a lot of programs where even though their volume was down, they did not, and the hospitalists were taking care of all these COVID patients, they did not step up, and hospitals were still admitting hip fracture patients, right, where they were not adding value, clinical value, I should say. So I think it's very important, but the first and foremost is do not engage in co-management without a well-written and clearly defined agreement. That's that to me is a recipe for disaster. So we have a list of references here, but we'll open the floor to questions to our audience. And I really thank David, Bill, and Deric for your candid thoughts, and we had a good conversation, I feel, about co-management. But there's a lot more work to be done. So let me try and read some of these questions. I'm trying to. So this is a question from Baker Engels. We are in the process of generating co-management service at our hospital. When thinking of ways to create admission criteria for co-management service, there does not seem to be any specific data on certain comorbidities that benefit from service most, based on what Dr. Atchley and the literature review have done. Do you have any recommendation on certain conditions that benefit most from your experience? So since David and Deric, you guys have seen some benefit from co-management, are there any conditions in specific that you would recommend where a hospitalist involvement would be beneficial? David, you want to go first, and then Deric?
In our situation, we're dealing mostly with perioperative patients, and certainly it's those who have significant medical conditions to start with, or a high prediction of those to be problematic post-operatively. We're able to help with that decision making through the pre-op clinic. Now, you may not have that available to you. So I would suggest starting with a service line director or chair of the department or division for the subspecialty service, and have that conversation with them and come up with a pilot, perhaps.
You know, in our situation, what we found is that it's impossible to create a comprehensive list. You know, there are just too many medical conditions to consider that can affect that plan. And we found that it was easier, not easier, but we came to better agreement whenever we looked at it from the surgical side as to which surgical cases we wanted to be involved in all of the cases, you know, especially in most orthopedic and certain trauma patients. We wanted to be involved door to door, but it was it became a much more simplified process when we started to look at it from which surgical indicators might be best for us to manage and maintain a lead role in.
Thank you. I think from my experience, I can just share one example. I think patients with end-stage renal disease who are on dialysis tend to do better on medicine service, just in general, and even with the pain medication usages and everything. I'm going to take a couple of more questions. Maya's asking, do you feel ownership is lost when the specialist is consultant instead of attending on a patient who comes in the hospital for their specialty reason? Mostly asking about the surgical cases. Bill?
I think that, yeah, I mean, I think that it is lost. I think that their sense of ownership and being responsive and taking care of things, it does go away. I mean, I think that is something that that's a whole thing about the unintended consequences of what we've been doing over the last 2 decades. Is that I think people, you know, particularly if you're a surgical subspecialist, I mean, you do your procedure and then you feel that you're done, and you sign off the case, sometimes without necessarily having the discussion with you know, with the hospitalist.
Yeah, I couldn't agree more. I think that's one of the pitfalls that we definitely see and experience on a routine basis. I think and I actually fear, and that's my honest fear, that at this rate, you know, we're on a slippery slope. I think it would not be, I think, I'll give you an example. When I trained 12 years ago, acute cholecystitis used to be a surgical diagnosis. And I think 12 years later, our surgeons sometimes get upset when we consult them for acute cholecystitis because patients apparently not a surgical candidate. But just to kind of give you an example how, I think the lack of accountability, I think I read recently on HMX, again, this is a great forum. I strongly encourage everybody to utilize that. There was a discussion about the hem-onc admissions, and then I think one of the comments was that, well, the administration is asking hospitalists to admit the patient because they are having a hard time finding oncologists to recruit oncologists who would want to admit their post-procedure or post-chemotherapy patient, which I think, in my mind, I think that's staggering. I don't know how we got to this point. I think if I put myself in a patient situation, here is somebody who is talking to you about your cancer, your prognosis, giving you chemotherapy, and now you have a complication from it, and you have a stranger walking in your room trying to take care of you, and the person who have been working with is nowhere to be found. I think that's the level of accountability that we're missing now. And I think that that's one of the biggest fear I have with co-management, that the accountability is going to continue to decline. Here we have a couple of comments that I would just read. Co-management also allows surgeons to be even more absent from the inpatient wards. George is here asking, anyone feel like they are often explaining the details of the operation performed or what they expect in recovery? How many times we have all experienced that? And then there's another comment about, I think it goes back to our skills and performing at the top of our license. We're not doing the work we are trained to do. That's one of the comments from our participant here. Pain management and the patient satisfaction argument is questionable. So that's kind of what they suggested. Gwen here, it's a long post, but I'll try and read that to everybody because it's a good post. It's interesting that majority of what we have discussed regarding surgeons' happiness or value and finance, but what about the well-being of hospitalists who are in the front line? Yes, it is great when co-management works and everyone is involved with an equal investment in the patient, but when it falls apart is when non-hospitalist consultant dump on the hospitalist. I think that word you often hear, dumping, or don't take ownership of their own patients. Yes, a hospitalist can sit down and talk to each patient, but the surgeon should talk with their own patient and not put on that hospitalist. For the lack of better phrase, hospitalists are not the bottom feeders or naked, but too often they are treated this way in hospitals. And even with co-management agreement, if you continue to expect hospitals to take all patients, then they need to be staffed appropriately. I think we touched upon staffing during our presentation. I think that's the key. If you're not staffed appropriately, don't even think about it. So, what do you think, Bill? I think.
Well, Hardik, I am reminded of watching Thomas the Train with my grandchildren growing up, and there's the one particular thing where Thomas feels put upon by Percy, the other train, and I think that that's sometimes how we feel, being put upon. And I've had some instances in the last couple of days where I have felt that, and that's got to stop. And one of the things we didn't really kind of touch on here is that really what's happened in the last 20 years is that now many of our subspecialty colleagues are using NPs and PAs, and that's just another layer of having to go through to have the conversation with the physician. That wasn't that way before, and I don't know how much of the impact of electronic medical records has led to this lack of communication. And we don't go to the physicians' lounges anymore. We're all in our little cubicles typing away on our notes. We may interact with each other on the floors if we see one of our colleagues, but otherwise, we're not out there. You know, Abraham Verghese at Stanford has kind of touched upon this and everything in terms of kind of, I mean, when was the last time you went down and looked at films with a radiologist? Not in a long while on it.
So I'll read a couple of more comments and questions. I think there's one which is pretty straightforward. What about the agreements that say hospital medicine will admit acute fractures greater than certain age? Like age is being, I actually have one of those agreements and I absolutely don't agree with it. It's as strange as it sounds. I think age should not be a factor. I think it should be based on the comorbidities and the risk. I mean, I can recall as recently as last week when I had a patient with who's 70-year-old, our cutoff is 70 here, who had hip fracture and had absolutely no medical problems, zero that she knew about. And labs picture perfect, actually looked better than mine, and I really had nothing to add in patient's care. So I kind of agree with that, but sometimes it's hard to get that message across. I think this one is a good question. I'll kind of have David and Deric weigh in on this. There are medical legal concerns in deciding who should be the attending, and not all co-management programs are well organized, as we kind of saw in our poll. About 50% don't even have one. I have done a significant amount of legal case review work, and one of the most common issue is delayed response intervention to new neurologic symptoms in patient who has undergone spine surgery. The hospitalist was left out on a limb waiting for a response from the surgeon. This is George Hope. He's sharing his experience and asking that question. A very valid question that is shared by a lot of our colleagues. David, do you want to take that?
That's a great question. I think from the beginning, if you're creating a co-management agreement, to be specific there and then pilot it and influence that surgeon or that subspecialist and say, you know, if this works well for 2, 3, 4 months and we can continue to get in touch with you when we need to, then perhaps we can make this permanent. Certainly, I remember years ago having similar issues. You know, make sure the hospital's medical staff bylaws support in that situation as well, and engage others and make sure that there's a teamwork approach. And if there's not a history of it, then make sure that's going to be true in a pilot. One other point as far as medical legally is many times there are new problems that show up that don't need to be addressed during that hospitalization. And hospitalists are good at handing those off, such as a pulmonary nodule, such as microscopic hematuria. And that can come back to bite a surgeon or another subspecialist if that information is not adequately communicated to the patient and handed off to the outpatient world. We can really help there and help the specialists share their medical legal risk.
You know, I just wanted to add, if I could step back just a little bit, you know, I can understand the frustrations of feeling, you know, dumped on, and I couldn't agree more that, you know, at our facility and almost all the facilities I've worked at, physician-to-physician communication has deteriorated to the point that it's almost non-existent. We almost look for reasons not to talk to one another anymore. And at our facility, we're planning to put together a task force to look at why that might be, because it is a universal issue. I think that there's exposure to medical legal, you know, risk and liability in an attending consultant role as well. Because you know, it's very likely that if there's no co-management agreement, the neurosurgeon will have elicited our services in the middle of the night anyway, and we still will have been expected to identify any, you know, abrupt neurological changes in any patient. I know that at many community hospitals, the hospitalist will serve the role as house physician, which means that even if I haven't been consulted or have a co-management agreement, it's still going to fall upon me to deal with those emergent issues such as abrupt neurological changes. So those liabilities are going to exist anyway. Better to be a part of the relationship from the beginning and be at least involved and be able to identify them early, similar to the patient that I mentioned earlier. I think that co-management relationships sometimes get blamed for other cultural shifts and shifts in the paradigm that might not be directly related to co-management. I think a co-management agreement that restores the value of a hospitalist service is going to have the opposite effect. The effect before of, I mean, we have lines that we're still admitting attending consultant role relationships with. And I'm just as often asked to take over a patient in which I have, very little to offer in that relationship as I am in those very clearly defined roles and relationships. I think that the patients who need my services outnumber the ones that you mentioned, that patient who's 45 years old and has no health issues. I think that patients who need my help and need my services outnumber that patient probably 20-1 in the hospital setting. Whenever I start to think about, am I needed? Am I just going through the motions? Am I redundant? I think about my patient like the one yesterday who all of a sudden had that facial droop and that left-sided weakness and needed my care more than anyone else in this hospital, at that very moment. So.
Great. I'm going to take a couple of more questions. I'm going to actually combine them because I think it would kind of, go together. I think the first question is from Michael, and he's asking, what is the funding arrangement for co-management agreements? A hospitalist fully support or surgical specialists contribute? And then the second one, I think to that line, and pretty much in that same zone, is what is the best way to get buy-in for co-management from the skeptical hospitalist partners? So I think, again, David and Deric, I would kind of defer to both of you to comment on those. How do you convince a skeptical hospitalist like me to do co-management?
Yeah, well, I've been able to be involved in several projects and work with the skeptics. The first thing I do whenever I have a skeptic in my group is I put them front and center in the planning phase, and they know that, which has discouraged dissent. But in reality, it's great to have detractors in the planning phase. As Hardik said, and I think we all agree, this is the direction of medicine. This is here to stay. This is where we are going. But I don't want to use that as my only argument, right? I don't want to leave it at, hey, nothing we can do about it. This is the way things are. We start every meeting and every project and every charter starts with our mission, which is to keep the patient at the center of everything that we do. And if you can focus on patient-centered values, it's difficult for physicians to argue against that. If you spend a lot of time talking about the negatives, which we typically try to avoid doing, they actually become a part of the routine, and you're actually likely to spend more time on the barriers that are going to come up and early identification of barriers and then working through those barriers, not as a reason not to proceed, but as rather as just a hurdle that is preventing us from reaching our ultimate goal. It is the key to making any change, and I don't think co-management is any different.
I think that's great input, Deric. To involve others in the planning stages, if we're being asked to do something that we're not doing yet, that means we have influence over how we're going to build it. And let's exert that influence and build it in the most positive, patient-centered way that uses everybody's skill set appropriately. If there's enough patients, then perhaps it doesn't have to involve every hospitalist. Perhaps there could be a separate group. We classify just a few of us as perioperatives, and because we serve on that service line, we get to influence it and perhaps have some scheduling benefits and so forth.
Right. Yeah, I think the key to buying. One thing I would say is, so our practice management committee at SHM did a value. We interviewed C-suite executives and kind of to get their perspective. Where do they see we add value? And as Bill mentioned in his remarks, that on an average, a full-time equivalent, there is about $198,750 investment per FTE of hospital medicine physician, as for the State of Hospital Medicine's report. And when that is being funded by the administration, and when we went back and asked them where they thought we add value as a hospital medicine group, whether you agree with that or not, one of the #1 things that they mentioned was how we support procedure-based specialty and build the service lines in order to expand our clinical scope. So I think that was definitely valued by our C-suite executives. So that's something I would kind of point out as a kind of a supporting argument. I would say I think you just want to do it right. I think having a written agreement, and we keep saying that, but that is the key. I think that's where everybody's going to feel valued. And I think it's equally important if we have any administrators on the call. I think it's equally important for the hospital administration to be part of that discussion and have that collaborative approach, and I think that would lead to success. And certainly I think just kind of answering question on the funding part, that is why we recommend that you actually have a metrics for these co-management agreements, and you track them and you see if it's cost effective. And if you find out that it's not, I think you need to really give it a real hard look and see if something needs to change there. So I think it's very important to, when you are in a co-management relationship, have metrics and track them and see if they are successful or not. I think I'll take this last one now. We have so many questions, like, it's a great discussion, but in the interest of time, Aaron asked here, he works in a academic institution where they do co-management on several surgical and non-surgical services, where a patient is actually admitted to the specialty team. Surgeons, advanced practice provider, and resident on the specialty team run the service. And he shares his experience that the APPs and residents on this team sometimes are bothered by having to deal with 2 different attendings. He's wondering if we have any suggestions on that. Bill, do you want to take that?
So the question is, they're answering the 2 different attendings so that there's variation in the treatment plan.
Right.
Yeah, that's a problem. I mean, that's a problem that I live with every day. I mean, cardiologist A comes in, and then cardiologist B comes in, and cardiologist C, and you're going, what's the plan here and everything? It's sort of interesting is that, and I've had these discussions with my subspecialty colleagues, mostly medical subspecialty colleagues. I said, why don't you guys really start doing what hospitalists do? Why don't you basically work 6 or 7 days or 5, whatever, pick a number, days in a row, seeing the same patient and everything, instead of handing it off to somebody else and then going off either to do procedures or going off to the office. And I apologize if you hear my dog yapping in the background right now. So I think it's downstairs, but I think that that's difficult. And I think what you have to do is you have to really go back then, and you have to really talk, to that servant and say, hey, there's a difference of opinion here. There's a difference of treatment plan, and you guys really need to collaborate and come up with an agreement so that we don't have this variation. We did that actually with our pulmonary service a number of years ago because of the variability that happened, and I think they got the message and they understood that there needs to be consistency. We can't have it changing day by day.
Well, unfortunately, folks, that is all the time we have for questions today. I just want to thank the panelists for such an insightful webinar. And just as a reminder, folks, a recording of this presentation will be made available later this week on both our online learning portal and our YouTube accounts. We also invite you to continue this discussion. A couple of emails from our panelists have been put in the chat box, so you're more than welcome to reach out to them as well. So just as we close, I hope you enjoyed today's presentation, and we look forward to seeing you at future installments of the Practice Management Webinar Series.
And I'll just add, thank you so much, David, Bill, and Deric, for your expertise and amazing comments. Greatly appreciated. And we will post, I think I'll plan on doing an HMX post with our contact information there as well for future questions. Again, everybody, thank you for your time, and I hope you enjoyed the discussion.
Hardik, can I just say one quick thing? I just want to do a plug for Converge. It's just happening in May. There's actually going to be a presentation on May 6th about, it's going to be called Co-Management in Every Shape, Size, and Style. It's going to be, I think, at 5:10 p.m. So I would encourage, if everybody wants to continue looking at things, you know, go ahead and register for Converge and attend that presentation.
Great. Thank you for that plug, Bill. Good night, everyone.
Good night.
Thank you all.